In the wake of COVID-19, calls have been growing for a better way of handling pandemics, a new global health architecture. The pandemic not only killed 6.7 million people around the world, but it also exposed and in many ways increased massive inequalities.
Wildly uneven and unfair, that's how the UN describes the distribution of COVID vaccines around the world. As rich nations scramble to buy up as much of the supply, many places are left out entirely.
The vaccination rates in Africa are ridiculously low. The only pathway for us to recover in this pandemic is for global vaccination to occur almost simultaneously.
While most countries in the developed world are offering their citizens a fourth booster shot, 2/3 of those on the African continent haven't been vaccinated at all. As a result, their people kept dying, economies in the global south struggled, and the virus continued to mutate. And while the West might have moved on from COVID, here's the thing. Research tells us there's a 38% chance there'll be another global pandemic in our lifetime. So what hope is there for a more equitable response the next time around? From Geneva, Switzerland, this is Rethinking Humanitarianism, a production of The New Humanitarian. I'm your host, Hiba Ali.
Now, there are fears that the coronavirus outbreak could become a pandemic. We now know there are confirmed cases in 35 countries. It's already classed as an epidemic.
Every part of the United Kingdom is now in lockdown, with people being urged to stay at home as the scale of the public health emergency becomes even more daunting.
2020 is shaping up to be the deadliest year in U.S. history. Early data from the CDC projects the nation is on track.
In response to COVID-19, pharmaceutical companies produced vaccines at record speed. But because of patents, trade issues, and rich countries' ability to negotiate with big pharma, the recipients of those vaccines were mostly in the global north.
90-year-old Margaret Keenan, well, she'll go down in history. She's become the first person in the world to receive the Pfizer vaccine against COVID-19.
The unequal distribution of vaccines around the world was supposed to be solved by a thing called COVAX, a global initiative launched by the World Health Organization, the Center for Epidemic Preparedness Innovations, or CEPI, and Gavi, the Vaccine Alliance. It was described as a lifeline for lower-income countries who would otherwise not be able to afford these vaccines, and for higher-income countries that had no bilateral deals with manufacturers. And it was meant to work like this. COVAX would support the development of COVID vaccines and get rich countries to buy at least some of their vaccines through the facility. By pooling funds, it would have greater purchasing power and could negotiate cost-effective deals with the vaccine manufacturers. It would also raise money and vaccines through donations, so that all countries that participated in COVAX could have access to the vaccines regardless of how much they were able to pay. But COVAX struggled to deliver on its promises, in part because wealthy countries opted out or struck their own deals on the side, and in so doing, ate up much of the available vaccine supply. So if not COVAX, then what? Today we look at what's needed to manage the next pandemic in a more equitable way. My two guests both worked throughout COVID to provide everyone in the world with equal access to vaccines and came up against a whole raft of challenges along the way. What ideas do they have for better governing the next pandemic, or for a new public health order at the international stage? Fifa Rahman is the global civil society representative on the World Health Organization's ACT-Accelerator. That's a global task force that was set up to promote the development, production, and equitable distribution of tests, treatments, and vaccines for COVID. She joins us from Leeds in the UK. Welcome, Fifa.
Hi, Heba. Nice to be here.
And Petro Terblanche is the managing director of Afrigen, a biotechnology company in South Africa that created Africa's first mRNA COVID vaccine. She joins me from Cape Town. Hi, Petro.
Hi, Heba. Thank you for the opportunity.
So, ladies, let's start with what's at stake here. What were the consequences, to your minds, of inequitable vaccine distribution throughout the pandemic?
Let me say two things. There's a negative consequence and there's a positive consequence. I think in the short term, the negative consequence was the impact on human health, quality of life, the pandemic just continue, and the absolute agony in low and middle income countries not being able to access vaccines. The positive consequence is that it has mobilized forces and organizations and support across the globe to never be in that situation. And what is the consequence is going to be that low and middle income countries will in fact build capacity, build the ability to respond to pandemics, and in that way also contribute to socio-economic development of those nations and those regions.
Fifa, what about you?
There's been massive gross inequity, and I think this laid bare what the problems were with the global health architecture, and definitely on the reform, where Africa CDC has said we need a new public health order, which is something that we've never seen before. And the political will on this is admirable and certainly something that we want to see.
So take us back to the early days of the pandemic when COVAX, this global initiative to provide vaccines to the world, was launched. And the vision was inspiring for many, the world coming together for a more equitable vaccine distribution. How do both of you reflect back on those days?
When the COVAX was announced in those early days, all parties aligned because it was the right thing to do. This is the one time that the world could stand together and solve a problem. I think the disappointment came when the alignment did not really reflect enrollment and that there were deviations from that initial absolute goal to stand together. Personal reflection, South Africa, we were surprised because we contributed to COVAX. We're a non-Gavi supported country, but we really wanted to do our part in creating Solidarity Fund to get vaccines for our people, and we couldn't even get vaccines for healthcare workers. Today, we understand many of those factors that influence vaccine hoarding and how nations wanted to protect their own people. And I think that is the learning that we have to bring into a new order of governance and responsiveness to the next pandemic.
Yeah, and just to reflect on the early stages of the pandemic, and in particular, two of the calls that we had with Gavi and CEPI as civil society on the ACT-Accelerator in the start. So one of these calls was on the target, so this 20% target of let's vaccinate everyone. And one of the main questions that we put forth to Gavi and CEPI and WHO even is, where does this 20% come from? Have you consulted with the governments of Burundi, with Democratic Republic of Congo? Have you spoken about the practicalities of getting 20% vaccinations by September 2021 and what's needed to deliver that? Have you considered that high-income countries were going to purchase all the supplies? So a lot of us were interrogating the sort of targets. What work has been done to getting to these targets, which we felt had not been done? And I think that's an important lesson for the next global pandemic response architecture is, what kind of LMIC intelligence are you using to construct these figures, which obviously weren't reached? And another one of the calls, a civil society call, where we were not allowed to unmute the call, not allowed to feed in unless we had flagged and somebody on Gavi or CEPI's side unmuted us. Now, this is at the start and very illustrative of how the power dynamics are in the current architecture. And while it improved as time progressed, I think it speaks a lot to how we govern ourselves if the people who have links to the ground, to countries and to patients, are not allowed to operate on a dignity-based manner and are not able to contribute our expertise in a way that is equitable and to co-create interventions. And that speaks also to a number of initiatives that were poorly led on the COVAX. So just in those two examples, you can see where the architecture could have done better.
There was this exchange on Twitter recently between Seth Berkley, the CEO of Gavi, the Vaccine Alliance, and Dr. Olusoji Adeyi, president of a Washington-based health organization and a former director at the Global Fund to Fight AIDS, Tuberculosis, and Malaria. And Berkley describes COVAX in this exchange as a blueprint of how to deliver vaccines at scale in an emergency to low-income countries. And then Adeyi pushes back. He calls Berkley's description spin and hubris and says COVAX had failed because of hyper-centralized planning, because it was captured and crippled by rich countries and special interests, and because it sidelined the Global South, as you were saying, Fifa. So I'm curious, you've both worked with COVAX in different ways. Was the problem poor execution against an otherwise good model, or was the problem the design of the model itself?
I think it's a combination of both, Heba. There wasn't enough LMIC intelligence informing the decisions. And there were so many calls throughout, not just vaccines, but also diagnostics and therapeutics calls, where I was like, why am I the only brown person in the call? Why am I the only person with an LMIC passport in the call? There's so many calls where I said that, and the ACT-Accelerator evaluation pointed that out, right? So what I'm proposing for a future pandemic response is to have an LMIC council, because low and middle income country experts, people with low and middle income country passports, including infectious diseases clinicians, CSO experts who are experts at community mobilization, public health people, epidemiologists, lab experts with LMIC passports and who are based in these countries should be on a council to review decisions that are made. And pandemic response needs to be quick. So this needs to be a panel that decides things very quickly, but at least it will come with context. And I know some colleagues disagree with me because they're saying every working group should have 50% LMIC participation. I completely agree. But I think that without some kind of structure like an LMIC council, it won't happen. In the COVAX, it was an issue of execution, but it was also a massive issue in governance. Why did DRC return those doses in the start? Why did South Sudan return those doses? Those are something that the COVAX, the folks in Geneva and New York and wherever people are based in the global north, they just didn't have that intelligence to know what the practical ground realities were.
Petro, as someone living in a middle-income country, are you as critical as FIFA is of COVAX as a model for the future?
I am. Even when vaccines were sent to African countries, vaccines which had very defined and shorter expiry dates, which in a high-income country could have been deployed in a period of a week. In low and middle-income countries, that was not always possible. So I do think there was not a deep and a compassionate understanding of what is the pandemic like in low and middle income countries and what is required to also protect half of the globe. COVAX, it was a combination of issues. I think the creation of a low and middle income country council is good, but where will the power sit? Where will the power of decision making sit? Unless we have a balanced approach to the power of decision making and a global commitment and value system that when we say nobody is safe until we're all safe, we actually mean it.
So, Petro, I'm fascinated by your story because Afrigen managed to create the first COVID vaccine on the African continent, a huge achievement. Tell me about the challenges you faced when trying to go about that.
It was part of the early days of COVAX response to address some of the low and middle income country challenges. This was WHO and partners coming together and making a decision to give access to technology, in this case mRNA technology for manufacturing. Secondly, to be able to share that technology in the most rapid possible way to complement production of mRNA vaccines for low and middle income countries. And in 21st of June 2021, WHO and partners announced the creation of an mRNA hub program to make mRNA vaccine technology available for low and middle income countries through a technology transfer agreement. That did not happen. Technology transfer were not able to happen from the owners in high income countries of technology. So the response from teams in South Africa, and supported hugely by technology institutions, the taxpayers in Europe, multiple countries, the WHO, was to then develop a platform. No longer have a product that will be transferred and fast-track vaccine supply to low and middle income countries, but taking a longer-term view, create a platform, mRNA platform for future pandemic preparedness and for the development of mRNA vaccines of relevance to the burden of disease in low and middle income countries. So this platform, which is in final stages of the development and which will be validated by a COVID-19 vaccine currently in preclinical development and going for clinical development, will be transferred to 15 countries in low and middle income countries. And in fact, 9 of the 15 countries already received first mRNA training at Afrigen to empower them to start the process of establishing these platforms. So this program has become a program that will share technology, develop technology, and enable low and middle income countries to have access to mRNA technology that will allow them to be responding to future pandemics, but also to have pandemic preparedness while delivering vaccines of importance to the burden of disease in the low tides where we don't have pandemics to respond to. So this is a long-term program. It is the biggest program in technology transfer in the history of vaccines. It is an ambitious program, but it's a program that surely and clearly is empowering low and middle income countries to have access to this very, very important platform for future response to pandemics.
And I've heard plenty of people argue that that is one of the way forwards, right? To develop that capacity for regional production of vaccines. But to some extent, that sounds like giving up on the global system. You know, if a global architecture cannot deliver a fair distribution, then we're going to have to build that capacity ourselves. To what extent have you given up, I suppose, on a global solution to have to go down this route?
So, Hepa, we haven't given up on the global solution. What we're saying, and going back to the new health order in Africa, what African continent is saying, we want to be more sustainable. We want at least 60% of our vaccines to be locally produced, but we need the global partnerships. For that other 40%, we want to build and work with global partnerships to produce and deliver the vaccines for Africa. This program has a socio-economic development imperative. It is also, apart from vaccine empowerment and ability, also bringing the value back to these continents as part of socio-economic development. So I have not given up at all on the global landscape. In fact, we are looking forward to partnering with high-income countries to develop new, fast, effective and safer vaccines for the burden of disease in low and middle-income countries. Again, we must not do what has happened before and have an exclusivity here. It has to remain inclusive and in a partnership model.
So just a last question on this regional production. To what extent are you and other countries in the South now ready for the next pandemic? What is needed to ensure this kind of capacity can exist at scale across various countries in the South?
So if we look at the 15 companies that will receive this technology, half of those are companies already in vaccine production. This mRNA technology will diversify their platforms and they move quite fast. It is quite impressive to see how some of these companies, already mature companies, are moving. In terms of South Africa and Afrigen, this facility here that has been created over the last 18 months will in 3 months from now be licensed and ready to have a pandemic responsiveness. This is end-to-end vaccine design, development and manufacturing up to 70 million doses in a fairly short period of time. So ready for pandemic preparedness and to be converted. What is profound for the African continent is there are about 17 programs and projects currently in development on the continent to build the capacity. Already we have built full finish capacity and already we have pledges for more full finish capacity. Our challenge is the drug product manufacturing and to have partnerships and more capacity being built to produce the drug substance and the drug product, not only full finish. The continent have come a long way in terms of our capacity building and our ability to respond in future. Are we ready for the next pandemic? Not yet.
So let me put to you another challenge, and it was raised by the CEO of Pfizer, the global pharmaceutical company that developed one of the earliest vaccines and, by the by, a revenue of $100 billion in 2022 thanks to it. Albert Bourla, their CEO, said recently at the World Economic Forum in Davos that the biggest challenge for him in producing and distributing vaccines was a politics of fear.
What was the result? Everybody tried to protect their own nation. So the protection is how it was manifested in our ability to deliver. Borders were closed. So you can't export vaccine. Europe was the only continent that were allowing part of the production in European soil to be exported, right? But at least there was the first 6 months of the pandemic that everybody was receiving vaccine from their own soil and everybody else from Europe. So for me, looking ahead now, how can we make sure that we can be better prepared to do faster in an unknown pandemic that we don't know what will be the nature of it? If the restrictions in trade were not imposed, but there was not a single country that they had full sovereignty, as you said it, in the manufacturing, because there were pieces that we had to import from Europe to the US, from UK to Europe, from from China, from India, from all over the world, that if any of them was closing as a retaliation, you're not allowing me to export vaccine, I'm not allowing you to receive nanoparticles. We should have some rules. Nobody stops anything, because otherwise we are all going to lose. But then we have an orchestrated way to have an equitable way of distributing.
So, Petro, I'm first curious about your thoughts on this, because he seems to be suggesting that it was governments and not the pharmaceutical companies that were to blame. Would you agree?
That's interesting. I think in the early days of the pandemic, there was just not sufficient capacity. Credit to Pfizer, to Moderna, to the big companies for really, Johnson & Johnson, AstraZeneca, increased capacity. We know that in the case of India, for example, was one country that closed their doors and Serum Institute could not distribute their vaccines. We're moving beyond a discussion that the model for the world, the most cost-effective vaccine supply model for the world, are large facilities of 2 billion, 4 billion doses located in high-income countries supplying the rest of the world. I think where the world have moved to is that there is a need for a level of self-sufficiency. And in fact, there is also a need for realizing value, creating jobs, creating innovation, contribute to own GDPs of countries, socio-economic development through vaccine manufacturing. We're looking for a hybrid model. We're looking for capacity in high-income countries, and some of it will be billions of doses, but we're also looking for a distributed model which has a different value proposition for healthcare and for looking after countries' own health needs. I don't think we can blame the lack of vaccine supply to Africa on governments. I think it was multiple aspects of factors that influence that.
So, Fifa, I want to turn to you, because he also talks about the need for a set of rules. So I hear you, Petro, that this is still dependent on some kind of charity model, but clearly it was a bit of a Wild West in terms of how this was managed, and the World Health Organization is now trying to develop a more structured approach through this so-called pandemic treaty, and it's just released its first draft, which would legally bind governments to support waivers of intellectual property rights and reserve 20% of tests and vaccines for countries that need it the most. So perhaps this isn't the more enlightened model that you're referring to, Petro, but Fifa, I'm curious whether you think countries would ever agree to rules like this.
I have yet to see political commitment and support and solidarity from the European Commissions and all the traditional actors who generally oppose TRIPS waivers. So while TRIPS waivers are absolutely necessary, and it is important that it's included in the pandemic treaty, I'm really not sure that these countries will agree with it, but time will tell.
If they did, Fifa, does this treaty deliver what you think is needed?
We've had treaties that haven't worked before. So what is the difference between this treaty and that one? There will really need to be a shift in power dynamics in how this treaty operates, because otherwise it will be business as usual. And that's precisely what we don't want. And that's where the issue about defining targets is important as well. The 20% right now for producers to mark, these are all predominantly global north producers. What percentage of this will be global south producers, and which percentage will be the global south producers that Petro is talking about? When I look at figures in the pandemic treaty like this 20%, I want to know the nuances and I want to know the detail. And the knowledge distribution in how this pandemic treaty is presented and the rationale for that 20% is really important for me to know, to be able to understand whether the lessons have been learned from the ACT-Accelerator.
For some people, entrepreneurship is in their bones. It's in their DNA. It's just what they were born to do. I'm Petro Raja, and I've been lucky enough to work with some of the world's most inspiring social innovators through my work at the Schwab Foundation for Social Entrepreneurship. These are the kinds of people you'll want to be hearing from, leading social innovators who are not only fixing a problem, but the root causes of these problems, and they're dedicating their lives to it. But hold on, there's so much more than that. In this special podcast series with the World Economic Forum and the Motsepe Foundation, we'll be learning about social innovators and what motivates these amazing individuals to do what they do. From the townships of Cape Town to the streets of Sydney, we're traveling around the world to bring you these amazing stories of resilience, passion, and innovation. Listen to Let's Fix It on Spotify, Apple Podcasts, our website, or wherever you get your podcasts, and make sure to tune in.
So tell me a bit more about the ACT-Accelerator, this global framework set up by the World Health Organization to ensure equitable access to tests, treatments, and vaccines, and with COVAX being the vaccine part of that accelerator. You represented global civil society voices on the Accelerator's Facilitation Council. What lessons did you learn from that experience?
So in terms of lessons learned from the ACT-Accelerator on the whole, there are so many. But from the evaluation, you'll see that the LMIC engagement and intellectual partnership of LMICs is something that was front and center. Accountability was an issue as well, where there was a certain number of resources and people didn't necessarily know where the money went and how it was translated into commodities. And it kind of brings us to the fundraising as well, where we need a facility at the start to be able to procure all these commodities, to deploy them early in the situation in the future where we know high-income countries will hoard. But there's another point as well about dignity-based practice that I spoke about earlier. There were some decisions being made about testing, for example, where people went, PCR only, because PCR is the gold standard. This was a very epidemiologist, lab expert-based decision, right? Because they want the best quality testing rather than considering accessibility to villagers in LMICs. This is sort of illustrative, just one example of how the power imbalance results in poor initiatives, and that applies to vaccines as well.
You talked about the financing piece, and throughout your career, you've worked on HIV, TB, malaria, all of these causes that have some degree of funding. So what have you learned from those experiences in terms of what works from a financing perspective, given, as you said, that the financing in this case was not in place when it was needed?
Definitely funding up front. It is the most important element of funding up front. And the fair share model that the ACT-Accelerator put together was laudable. It was important that there was fair share by different countries, including countries in the global south. But at the same time, there needs to be an understanding that because the ACT-Accelerator didn't sufficiently engage LMICs, why would LMICs give money to a platform that didn't necessarily engage them, value their input, right? So we need a new platform for sure, and perhaps the WHO new architecture that they're proposing, the new countermeasures platform, will be more equitable. My thoughts are about the global health architecture is that it needs to be global south owned or global south led, and it needs to have that ownership.
But that's not where the money would come from.
Well, the money needs to come from everyone. There is still value to global response, right? And I don't want to be all negative because the COVID vaccine delivery partnership, for example, has done amazing work, but it just was established too late.
The independent panel for pandemic preparedness and response that was established by the WHO during COVID to kind of think through lessons learned has recommended what it's calling an international pandemic financing facility so that there would be reliable funding for pandemic preparedness and for rapid kind of surge financing when a pandemic happens.
A model of relying on, in effect, charitable funding didn't work terrifically well. And we're now seeing with the establishment of the pandemic fund for preparedness, conventionally agreed, I think that you need around 10.5 to 15 billion a year being put into support for low and middle income country preparedness efforts. They will, of course, contribute a lot themselves. Our panel advocated that any future fund should be set up using these principles, where you set up on a sort of member state basis on an ability to pay from each according to their means and to each according to their need. That would mean, for example, that Mozambique as an LDC would pay in a very, very small amount. But of course, when it came to the allocation, would be getting a significant allocation along with other LDCs. So
is that what you think is needed? Is that what you're looking for?
It's certainly what I would support.
How would it work? What incentivizes them to put money into a fund like this?
I wish I had a better answer for you because the World Bank's Pandemic Fund hasn't had enough donations either. It's quite a small fund and they've just opened the grants for countries to apply to do preparedness work and surveillance work and other things like that. but it's a really small pot of money. And judging by the country responses to that, I can't help but be a little bit pessimistic as to what will go into the financing facility for the next one. But I also want to be careful because I don't know how much of this is pandemic funding fatigue. But it certainly does look pessimistic if we're basing it on the pandemic funds fundraising.
Petro, did you have thoughts on this?
In terms of the funds, the Pandemic Preparedness Fund, I think a huge factor is the war in Ukraine. It has affected the ability of funding. It has affected the ability of the World Bank and the European Union to contribute. At the same time also, if I was a government that wanted to contribute, I would want to understand what are the governance structures, what will be the impact and the benefits of such a fund. And I think those conversations are happening at many, many levels. The other point that I wanted to make, you're all aware of the Berlin Declaration. The innovative pharmaceutical industry partners came together and they issued the Berlin Declaration. And what it actually says is we will have capacity to supply the world in time of a pandemic. The question I immediately had, is that where the funds are going to go to? Because also in the fast track of developing COVID vaccines, most of those were funded by public money. And that is a fantastic thing because it would have been very difficult to reach this phenomenal timeline of within 12 months to have a vaccine or effective, safe vaccines. I am cynical a little bit about resources, where the money will go. And I think there needs to be good, rigorous debates by multiple parties and a redefinition of the value system if we want to build a pandemic preparedness world that is still prepared in 10 years from now, not only in the next 6 to 8 months.
I was at the World Economic Forum in Davos back in January, and Helen Clark, the former Prime Minister of New Zealand, who co-chaired the independent panel, was listing a lot of the initiatives underway to better respond to the next pandemic.
As we know, COVID ain't over us and requires a continuing level of focus. I'm actually quite encouraged at the number of trains that are moving in response to not only the independent panel report, but a range of other reports and recommendations too. You do have negotiating processes in Geneva for a new pandemic legal instrument of some kind. You have the International Health Regulation review process underway. You have the pandemic fund at the World Bank. Not a lot of money in it yet, but it's work in progress. WTO made a little progress, but I'd like to see more. But countermeasures, there's a lot of discussion. I think there's still a bit of a gap about what leadership and oversight is needed going forward, and our panel was clear that really keeping the focus of world leaders on these issues through a kind of Global Health Threats Council is very, very important. I think there's a chance to keep the focus on and get the lasting reforms that we need to do better next time, learning from this rather sad experience of the last 3 years.
You both expressed quite a bit of skepticism about the future, particularly when it comes to the financing piece. What do you think are the most encouraging developments since the pandemic?
There was a real lack of funding for diagnostics in the ACT-Accelerator. Everybody wanted to fund vaccines only. And as a result of that, of course, we don't know the full scale of infections in the global south. There's some movement on testing as well, and that there are testing facilities being built as well. And in terms of what Helen Clark said, I think these discussions are really positive as well. And I'm part of these conversations. And I think that ACT-Accelerator lessons are still fresh in people's minds. But I think the longer it drags out, the more we'll forget those lessons and they may be diluted. So these things need to move quickly.
Petra?
I think some of the great developments on diagnostic, FIFA just mentioned, suddenly on the continent, there are pockets of capabilities in diagnostics that has now been supported and is developing. The whole issue around genomic surveillance in low and middle income countries and globally. There are huge initiatives to build these networks to understand and to monitor and have credible genomics surveillance across the globe. I think that is fantastic. Technology transfer, if we look at the number of technology transfer programs to low and middle income countries, pre-2020 it was non-existent. There are probably a 10-fold increase in technology transfer initiatives that will build capacity and will enhance capacity. So I do believe the world has recognized that we need significant change in access, in resources, and in the governance globally if we really want to survive the next pandemic and if we want to recover from this one, which is going to take us years. I think we have a huge, huge challenge in leadership. If we had another pandemic today, who's going to take the leadership? Who's going to make those decisions on what is best for the globe? Who's going to ensure that there's fairness and equity? And I'm not sure that that leadership position, if I can call it, has been fully taken and fully empowered.
And that's just the point I wanted to come to, because a lot of the progress you both described sounded, as a non-expert, to be taking place in the technical realm. But does it ultimately change the dynamic that the world is still relying on goodwill and cooperation to propel a fair and responsible pandemic response? So can we ever expect governments not to act out of national self-interest and to show the kind of leadership you're describing, Petra, or is that kind of a lost cause?
I think countries will act in self-interest. In future pandemics, we can't expect vaccine deployment platform to go, yes, we'll provide vaccines to the world. I think the targets need to be a lot more realistic. It really needs to be a more pragmatic rather than lofty saviorism-based approach, because that's just not going to work in the next pandemic.
Fundamentally, we're not going to change human behavior. We need to look at how do we create that ecosystem that will support sustainability and maybe protect us from certain behaviors that's not in global interest.
We've talked about a lot of things, from the need for financing and a fund, from the regional production that Afrigen is trying to spearhead, from the need for greater leadership. We try to end these big conversations around structural changes to global architecture by identifying starting points. So if there was one practical starting point towards a more equitable pandemic response in the future, what would you point people towards as a good place to start?
Democratize the rooms you're in. That is the foundation of everything. If there's no vaccinologists, there's no public health epidemiologists, if there's no civil society experts who speak to communities in the room while you're making these decisions, and those from LMICs, your decisions are going to be flawed.
I'm very close to FIFA. I wanted to say to ensure that we have an evidence-based approach, which is inclusive. There's lots of decisions being taken without a deep understanding what the true intervention is and what the impact would be. Let's work from an evidence-based position, and that evidence applies to a village somewhere in Africa.
Our guests today were Petro Terblanche, Managing Director of Afrigen, and Fifa Rahman, the Permanent Representative of Civil Society on the WHO's ACT-Accelerator. So was COVAX a failure? Was it its fault? What could be done differently ahead of the next pandemic? If you've got thoughts on this episode, write to us or send us a voice note at podcast@thenewhumanitarian.org. Before we go today, I want to share some audience feedback. You'll remember a few episodes ago, we spoke to Uzo Iwala, Thomas Kramer, and Kizito Bienkia about reparations for colonialism. And in response, we heard from a listener who wants to stay anonymous, but told us she's a third-generation Holocaust survivor whose grandmother received reparations from the German government. She warns that the reparations model was far from perfect and actually led to more inequality.
For example, Israel set up a criteria to who gets the money. That was something that can be described as unequal. Even within affected and traumatized communities, you can create an hierarchy. And that is a highly damaging thing for survivors who has to prove they have suffered more than others. The main group that was not eligible were those who escaped Nazi Germany and fled to the Soviet Union, like my grandfather, who was forced into labor camps in Siberia. The other group was the Northern African Jews that were also enslaved during German and Italian occupations, but these work camps were not recognized as concentration camps. With this decision, the gaps between the European Jews and the African, mainly Arab Jews, was widened, and I believe reparations affected this gap for generations. My grandmother's reparation for sure impacted her social status and allowed our family to rise to middle-high class status. This is something that was not afforded to North African Jews.
Interestingly, since we broadcast that episode, the Dutch Prime Minister apologized for his country's role in the slave trade And a British slave-owning family announced that it would pay reparations to the people of Grenada, where it owned 6 sugar plantations. I must say, this was one of the most interesting episodes of the season, so do go back through the feed and check it out. It's called Give Us the Money, Aid as Reparations. Today, we'll leave you with a clip from Dr. Juwadi Alakija, co-chair of the African Union's Vaccine Deliverance Alliance. And here she raises a different angle on this whole pandemic management question. She was interviewed by the BBC shortly after South Africa had discovered the Omicron virus and was punished and blacklisted for sharing its findings. Take a listen to her thoughts on how African countries were treated differently than the rest of the world. This podcast is a production of The New Humanitarian. This episode was produced and edited by Marta Vanderwolf, original music by Whitney Patterson, and I'm your host, Hiba Ali. Thank you for listening to Rethinking Humanitarianism.
Had the first SARS-CoV virus, the one that was first identified in China last year, originated in Africa, it is now clear that the world would have locked us away and thrown away the key. There would have been no urgency to develop vaccines because it would have been expendable. Africa would have become known as the continent of COVID. What is going on right now is inevitable. It's as a result of the world's failure to vaccinate in an equitable, urgent, and speedy manner. It is as a result of hoarding by high-income countries of the world. And quite frankly, it is unacceptable. These travel bans are based in politics and not in science. It is wrong.